In order to keep everyday things in our lives organized, we group like things together. Groupings can take the form of classifications or categories. We classify our cars based on the size or gas mileage, from subcompact to luxury, whether they have a gasoline engine, hybrid, or all-electric. From these descriptions, we may formulate an idea of the environmental impact of a vehicle, or maybe from the financial standpoint, the cost of operating it or insuring it. The Dewey Decimal Classification System is used in libraries across the country to organize books into groups according to their content, fiction, nonfiction, or reference, and file them in the appropriate sections of the library. The purpose of this system is to save us time in searching for information we need. All known elements on Earth are organized into the periodic table, grouped together based on the similarity of their atomic structure. When we fly on a plane, we may sit in economy, business, or first class, and we will be sitting with other passengers who paid a similar premium for their seat in that section, even though we are all unique individuals and may have different final destinations. The average person may not realize they're being classified into a category when they become a patient, but a high priority of the hospital is to get the patient to the right location for the right care. I want to give you a brief history of the concept of patient classification systems, why they were developed, shortcomings of the earliest systems, why Medicare and Medicaid improved the focus of patient classification systems over the years, how the Affordable Care Act of 2010 and the Health Information Technology for Economic and Clinical Health Act of 2009 have brought medical record keeping into the modern age, so that sharing patient information and detailed data collection will allow real-time data analysis and continue to improve patient outcomes and the role patient classification systems will play. Classifying patients based on need is a common sense concept which has been around since the time of Florence Nightingale. On Miss Nightingale's ward, sicker patients were placed near the nurse's station to be monitored more closely and allow for more frequent interventions. In the emergency room, patients arrive and are screened by the triage nurse, who evaluates them and assigns them into a classification based on the severity of their injury or the acuity of their illness and how quickly he or she needs to be seen by a doctor. To put into words what a nurse does during a shift takes time to articulate. Nurse work is not easy to define. Now imagine taking those actions and critical thinking and transforming them into a numeric system, so calculations of patient needs and projections for future staffing needs can be quantified. The task has proven to be inefficient and ineffective in early manual calculation models. Nursing care has become increasingly more complex as patient acuity has increased over the years. How do you measure caring? How much time is sufficient to console a patient who has just received a terminal cancer diagnosis? Or a newly diagnosed diabetic about the major life changes he will need to make to manage his disease? How much time should be allotted to comfort the parents of a small child who has just died? These are real human moments requiring the whole and dedicated presence of a real nurse. Before Medicare and Medicaid were initiated, health care access was limited to more affluent members of society, and reimbursement was based on services rendered. When Medicare and Medicaid were signed into law in 1965 by President Lyndon Johnson, healthcare became more readily accessible to the poor and the elderly, and patient census in hospitals across the country rose dramatically. Patient classification systems were developed during this time in the 60s out of necessity of this increase in patient load, in an effort to calculate the needs of these patients and provide appropriate staffing levels of caregivers to meet those needs. Early models of PCS contained only a few categories, likely a patient's ability to bathe, feed himself, or ambulate without assistance. Acuity levels were selected by the nurse managers and based on chart review, so descriptions were subjective. and these factors provided an inadequate clinical picture of the patient. Because calculations were manual, collecting more details about a patient would have made the process too cumbersome, and timely calculations would have been impossible. Patient classification is a logical theory, but extremely difficult practice. Initial attempts for calculation of patient needs in nursing care were focused on tasks, which quantified time required for nursing actions in the same way your car repair time and cost are calculated, based on averages of how long it would take a skilled person to perform a particular task. For example, if your car is damaged in an accident, the body shop may give you an estimate of 1.5 hours to replace your damaged bumper and another 3 hours to paint your car. However, each patient is unique and has unique needs, and nursing skills also vary, so any blanket type calculation falls short. A nurse may be able to place a Foley catheter in a healthy male in less than 10 minutes. That same nurse may take more than 30 minutes to place a Foley catheter in a male who has an enlarged prostate. She may even be unsuccessful after an hour and need to have the catheter placed by urology. Having early models which only reflected the time requirements to complete patient care tasks were also lacking quantification of the critical thinking and care planning work of nurses. Extra time may be required to calm a child before or after an injection, or to reassure a patient with a frightening diagnosis and provide education about a disease. Nursing care is more than tasks, and patient needs are more than physical. Emotional requirements had to be added to the mix, not only for the patient, but the family members as well. Patient classification systems evolved with more details, not only of the empathic presence required for emotional support, but the professional knowledge obligations nurses have to teach patients, plan their care, and provide the best care. In the 1980s, in an effort to improve efficiency of care for Medicare and Medicaid patients, reimbursement changed from payment for services rendered to projected reimbursement. The new payment system utilized diagnosis-related groups, which designated services that should be provided and the time allotment from admission to discharge. Hospitals had to become more efficient in providing not only the appropriate care, but decreasing the amount of time to provide that care. The need to manage the cumbersome complexity of staffing and classifying patients brought about the development of numerous PCSs during this time, with primary focus on using technology and computer data analysis to measure productivity, provide quality staffing, and meet regulatory requirements. By adding electronic data collection, more patient details such as emotional support and patient education needs could be collected and integrated into the calculation. The clinical picture of each patient was becoming clearer, and improvement in providing the best care was becoming easier. Providing the best care has always been the plan, but in truth, providing the best care which will yield the best patient outcomes is now the focus. To provide the best care will require the best possible staffing. According to the American Nurses Association, appropriate nursing staffing is a match of registered nurse expertise with the needs of the recipient of nursing care services in the context of the practice setting and situation. The provision of appropriate nurse staffing is necessary to reach safe quality outcomes. It is achieved by dynamic, multifaceted decision-making processes that must take into account a wide range of variables. The first push into using available technology to improve patient classification systems occurred in the 80s when Medicare changed to the reimbursement based on diagnosis-related group. The Affordable Care Act of 2010 and the Health Information Technology for Economic and Clinical Health Act of 2009 have pushed hospitals to convert to electronic health record keeping. Besides the advantages of improved communication between providers and improvement in continuity of care, the opportunity to add details for collection of valuable data and to integrate this data directly into the hospital resource management software will allow institutions to coordinate up-to-the-minute staffing requirements. The patient classification system of the past required subjective evaluation by nurse managers and tedious and time-consuming manual calculations. Times have changed. Technology and electronic health records are allowing for collection of more and more patient details at the bedside by the nurses providing the care. No longer based solely on self-care needs, now cognitive needs such as patient's education level, cultural details such as language barriers, emotional and spiritual needs, support for family members, pain assessment, treatments, communication between disciplines, and transition planning are all considered. Each detail added and collected will paint a vivid, objective clinical picture of patient acuity and need for care, and more detailed plan to provide the right nurse to meet those needs. Federal regulations have pushed healthcare into the electronic age, and patient classification systems improved as a result. But they must continually evolve to keep pace with the ever-evolving scope of medicine, increasing acuity of our patients, and the dynamic role of the professional nurse. Thank you for listening.